Good morning, everyone. Mine would be a case paper presentation. I'm Dr. Lincoln from DNB resident from Dr. Hedgewar Rugnalaya. I'll be presenting my case under guidance of Dr. Megha Vani ma'am. On dorsal pancreatic agenesis. Dorsal pancreatic agenesis is a very rare anatomical variation of the pancreas, which is characterized by either partial or total loss of body and tail of the pancreas. The disease as such has no specific clinical symptoms most of the times, but may accompany pancreatic secretion insufficiency and other pancreatic diseases. In most of the cases, this is diagnosed incidentally by chance. Now, embryology of the pancreas. Actually, the pancreas develops from two birds, ventral bird and dorsal bird, which arise at the junction of foregut and midgut. Further, the ventral bird undergoes a rotation of 180 degrees to fuse with the dorsal duct in order to form the complete pancreas. The dorsal duct forms the head, part of head, neck, body, and tail of the pancreas, while the ventral duct forms the uncinate process and the head of the pancreas. Coming to the cases, we had two cases. The first one, in this case, there was a 27-year-old female patient who presented in medicine OPD with complaints of nausea, vomiting, and abdominal pain. See, at the age of 27 years, she was a known case of diabetes mellitus. CECT was advised, which further showed such kind of picture. As you can see, the head and uncinate process of the pancreas are well visualized, but the body, tail cannot be seen. When we see at the splenic vein, we can see that the bowel is lying just adjacent, it is abutting the splenic vein, which is known as a dependent bowel sign. In the coronal images as well, we can see that the head and the uncinate process of the pancreas are not visualized, while we can well see the head and uncinate process of the pancreas, while the body and tail of the pancreas are not visualized, and we can see the stomach abutting the splenic vein, which is known as dependent stomach sign. So overall, we can say that the CT scan showed the head and uncinate process of the pancreas with absence of body and tail, with dependent stomach sign and dependent intestine sign, which were seen as the stomach and small bowel lobes lying in the distal pancreatic bed directly anterior to the splenic vein. Now, coming to another case, it was a case of a 60-year-old male patient who was a known case of hypertension, diabetes, and CKD. He was subjected to USG. There were several findings in USG, but nothing related to the pancreas, nothing significant. He further underwent CCT abdomen and pelvis, which further showed, yet again we can see the head and the uncinate process of the pancreas are well visualized, while when it comes to body and tail, they are not seen, and the stomach bed is lying in close proximity or is just abutting the splenic vein. Yet again, a case of dependent stomach sign. In the coronal images as well, we can see the head and uncinate process of the pancreas along with dependent bowel sign, in which the bowel can be seen in close proximity to the splenic vein. Now, what are the differentials of this condition? There is mainly two differential: the pancreatic lipomatosis and pancreatic atrophy. How to differentiate? In cases of distal pancreatic lipomatosis, abundant fat tissue is seen anterior to the splenic vein. Similarly, in pancreatic atrophy also, there is fatty replacement anterior to the splenic vein. While in contrast, in cases of distal pancreatic agenesis, the distal pancreatic bed is occupied by the stomach or intestine, which abuts the splenic vein directly. I'll be presenting a case of, there is a differential case of pancreatic lipomatosis. Here we can well see that although the body and tail of the pancreas are not visualized, but we can see that there is abundance of fat in that region, and the stomach and the intestine is lying away from the splenic vein. It is not directly abutting it. Hence, this differentiates it from the case of dorsal pancreatic agenesis. Conclusion: agenesis of the dorsal pancreas is a very rare congenital disease with an unclear pathogenesis that may present with multiple symptoms. It should be considered when the patient have non-specific, persistent, and unexplained symptoms such as bloating and uncontrolled blood sugar. In approximately 50% of the cases, although associated hyperglycemia is usually noted, imaging is quite helpful in the diagnosis of this condition. Thank you so much.
Beautifully depicted cases, and it was just one question.
Yes,
any presenting symptoms, or these were also incidental findings?
No, sir,
in your dorsal?
In my cases, sir, these were incidental findings. Although it was a 27-year-old female was a diabetic, but there were no symptoms as such. She was hyperglycemic, but as such she didn't present with such, symptoms which are related to distal pancreatic agenesis, dorsal pancreatic agenesis.
Okay. Thank you.
Thank you.
So any role of MRI here? Did you try MR in these cases, or can it add to something, or it's not needed? Did you go through any references for this?
Yes, sir, I did went through references, but in most of the cases, in our cases, we didn't subject the patients for MRI. But MRI can be shown in order to differentiate it well from the pancreatic lipomatosis in order to visualize whether there is fat or not. So, to differentiate from the differentials, it would be better if we want to be sure whether it is dorsal pancreatic agenesis or pancreatic lipomatosis. That might help either from apart from the CT signs which are seen.
Is there a dictum that if there is dorsal pancreatic agenesis, then all these patients have to be diabetics?
No, sir.
You must have read a lot.
No, sir, it is not a dictum that then, according to the papers, in 50% of the cases, the patients presented with had problems of hyperglycemia, but it is not a dictum that they need to be diabetic or hyperglycemic.
So that means it's just a finding.
It is
has
just
no
a finding.
clinical
No,
significance
sir, no.
If at all the patient doesn't have anything.
Yes, sir.
Thanks.
So you have mentioned pancreatic lipomatosis as a differential diagnosis.
Yes, sir.
Do you get this focal pancreatic lipomatosis or
Yes.
diffuse?
Sir, we get both a diffuse pancreatic lipomatosis as well, while focal pancreatic lipomatosis as well.
Because I think in pancreatic lipomatosis, most of them are diffuse.
Yes,
so
sir.
you will not identify the head and neck also.
Yes,
in
sir.
that cases.
In some of the cases, like if the pancreatic lipomatosis, for example, let's say it is associated with few conditions like cystic fibrosis and all, in those cases we see complete entire pancreatic lipomatosis, and nothing is seen like either the head or body or uncinate process. But there are a few cases in which there is head and uncinate process, while the body and tail are replaced by fat. So that is a case of focal pancreatic lipomatosis.
In that case of lipomatosis, have you ruled out cystic fibrosis?
Yes, ma'am.
How?
The patient underwent investigations, ma'am. Pathological investigations were done, and apart from the other, he was not in that case also. That was the patient was not having any symptoms. It was also an incidental finding in case of pancreatic lipomatosis as well.
To ask you, how did you rule out cystic fibrosis?
Sir, the patient underwent pathological investigations by.
What investigations? That is exactly what she's trying to ask.
Blood investigations were taken, sir, along with mostly, sir, the biopsy was taken from renal biopsy was taken along with some.
Thank you.